Hi everyone, my name is Zhang Shichuan. I am a third-year master's student majoring in computer technology in University of Chinese Academy of Sciences. I have engaged in the research of computer vision, machine learning, and medical imaging. I am passionate about the application of artificial intelligence in biomedical field and dedicated to make contributions in healthcare. Today I'm going to share my previous work, which is about heart disease classification. My talk will be divided into 6 parts, including background, research status, purpose and methods, result, and discussion. Let's move to background. Foramen ovale, a hole in the wall between the left and right atrium of every growing baby's heart, serves as a left channel to deliver blood when baby is not exposed to air. As you can see from the top left picture, the circle area should be focused, where the left and right one is atrium, and the middle channel is the foramen ovale. Normally, functional closure occurs in the foramen ovale after baby birth. However, according to statistics, this defect does not close and remains in 15 to 35% of the elder population, which is termed as patent foramen ovale (PFO). PFO is experiencing increasingly clinical interest because recent clinical research has found that PFO has associated with cryptogenous stroke, migraine, decompression sickness, and other disease. There are many methods to detect PFO and mainly ultrasound, but they all have some limitations, which I will introduce later. Conventional detection methods cannot detect the disease, while multiple screening tests are often required. CT and MRI have low detection rates in PFO diagnosis and are generally required to exclude other diseases in a preliminary stage. As for therapy, the current treatment methods has been mature and effective, especially after interventional therapy. An umbrella-shaped device is usually implanted to reach the foramen ovale in the chamber and is extended to block the foramen ovale. From post-operative follow-up experiments can effectively reduce the recurrence of the above syndromes. So, if PFO can be effectively detected in the early stage, it is very necessary for a subsequent diagnosis and treatment. There are currently 4 methods of clinical diagnosis of this disease. The first one is the golden standard, TEE. As you can see from the top left video, the ultrasound probe is really inserted into the throat to avoid blocking the lungs and other organs in order to obtain a clear image of the heart. So it is highly sensitive for clinicians to use this technology. But there are 3 limitations. This method is semi-invasive, which will make patient be more painful and rely heavily on clinicians' experience, which really need 2 to 3 physicians to make collaboration. In addition, this method is quite expensive and is not available in China. The second one is CTCD. CTCD use microbubbles of saline injected intravenously and transcranial ultrasound to detect blood vessels in the brain to see if there are microbubble signals, but it just makes an indirect inference, and the specific source of microbubbles cannot be identified. The third one is the TTE. The very regular TT imaging is non-invasive and simple operation, but with low detection rate, where clinicians rarely use to diagnose. The last one is CTTE. As a new detection method, CTTE was performed on the basis of TTE, and normally saline was injected after concussion as conscious agent. And whether PFO was detected by observing whether there were microbubbles from the right atrium to the left atrium. It is currently considered as the most commonly used test except the golden standard TEE. However, this detection method is easily disturbed by noise and motion artifacts, which often results in high specificity and low sensitivity. According to large literature reviews, almost all the PFO research work are from clinical perspective. Only one PFO study from 10 years ago can be found from engineering perspective. It was the first attempt to study PFO by engineering methods, which proposed to simulate atrial environment by noise experiment and distinguish microbubbles by spatial differentiation algorithm. However, the data set was very limited, with just only 2 cases. But the idea from this study is really novel and should be referenced. All at the same time, engineering research in the direction of the heart mainly focus on ventricle segmentation and evaluation of ejection fraction, and conventional cardiac perspective classification and common classification of multiple disease, such as 2019 Stanford University's EchoNet project. According to clinical status and engineering status, no new and effective method exists. That is where and why we have started our research. Our vision is to explore the feasibility of painful over diagnosis with artificial intelligence with the current clinical methods, and hope to achieve a simple, operative, non-invasive, and high efficient and automatic methods to diagnose this disease. And our collaboration partner is Beijing Tiantan Hospital's ultrasound department, whose neurology department is the top tier in China. Potential patients were all suspected of a potential PFO after preliminary diagnosis from the neurology department and are sent to the ultrasound department. As for research methods, except the golden standard CTTE, and the clinical usually will use the CTTE methods to detect the disease, but two very important issues should be considered. The first one is the interference. It's widely known that ultrasound image has its own image noise, which causes the image quality in a really bad status, while the faster heartbeat had caused the image increment to a delightful time, so that we can very easily get the image which with some white lag, both of which may greatly influence the subsequent bubble detection. In addition, the region of interest, the left atrium, is quite different from the left ventricle, which has attract lots of clinical attentions to, such as there's some just left ventricle segmentation to measure the ejection score then to evaluate the patient's heart status. Left ventricle will sometimes appear in complex structure, and so I think there are a lot of huge works first to screen out the interference data. So there may be a lot of work first to screen those unvaluable images. On the other hand, bubbles should be focused. Bubble is quite strange or eccentric. Whose numbers and volume are too small. It is very different from the previous slide. The bottom right corner, this is very typical pattern for oval, and we even just can discriminate bubbles by our eyes. That is a very typical one. However, in real status, there are few bubbles in the left atrium. According to some clinical status, bubbles should be appear in the 3 to 5 cardiac cycle after right atrium is full of the conscious age. Is one of the most challenging tasks we have to focus, because this is quite different from the natural image, and the bubbles are just too small, and sometimes the clinician have to play the CTD video back and forth in order to locate and detect the bubbles. And in addition, the bubbles are non-linear characteristics, which means the faster heartbeat has just shaped the bubbles into an irregular shape, and sometimes maybe a clustering or just ejecting. So we can use very standard or very simple geometric structures to describe what the bubble should like. So I think this may be another important issues that should be focused. We have done lots of experiments and make a lot of literature review. We hypothesize that we may use the very normal 2D imaging and the CTD imaging video, both of the two videos, and from time domain, we propose a method to reduce interference, which focus on the noise and motion artifacts. Whereas in space domain, we develop a method to locate and detect the bubbles. First step, we just make we do some preprocessing work, which includes about just crop, spectral reduction, and just some standardization. Which is very essential for the subsequent analysis. And the second stage is the left atrium segmentation. We just focus on the left atrium, so we should make a segmentation of this area. We have utilized UNet, Deep Lab V3 Plus, or even just object detection algorithms such as FastCN to detect the left atrium. Surprisingly, it's very easy for the UNet to achieve good results. So we just utilize UNet to make segmentation. The bottom left is the network structure of the UNet, and the bottom right is the training and validation loss of the segmentation. As we can see from the bottom left corner, the green one is the asperse delineation, whereas the red one is automated segmentation by algorithm. Uh, I think in this project, the important thing is just not focus on the segmentation. So we just do the work in this level, and then we have also achieved dice scores on 0.92. I think it's quite enough for the subsequent analysis. The third stage is very important in talent domain. We propose a motion artifact removal methods to select some interference, some low interference images sequences in CTT imaging. After the left atrium segmentation of TT and CTT imaging, we just use private knowledge of TT image. We just calculated the grain distribution of a whole TT cardiac cycle. The lowest range interval may be lowest interference areas, and then we got an interval such like 25% to 45% this area. We project this area this range intervals to the CTT imaging's complete CT imaging's cardiac cycle. In this way, we just use private knowledge to project areas to the CT imaging. That is to say, in this picture, the top middle one is just a straight cardiac cycle of TT imaging, and the middle one is just a mean grain level distribution map of TT cardiac cycle. That is a whole cardiac cycle, and then we choose area. As we can see, just 25 to 45%, and then which is the same as in the a full ECG diagram. In this stage, and they're make some experiments to test our hypothesis in a complex cardiac cycle. The start and end is both the cardiac systole, which means the heart contract, and then in the middle one, cardiac diastole, which means this moment is in dilation. So in this stage, and at this stage, the grain level in the left atrium will be as low as possible. So we use this private knowledge to project the lowest interference range intervals to the CT imagings. Later, we use those sequences that we have selected in this stage should be focused on the subsequent analysis. In space domain, and we inspired by the calcium point detection in breast cancers, and we developed a superpixel segmentation methods which called simple linear alternative clustering. It is an algorithm that, under a constraint of the color and space similarity, and in the very first stage, this algorithm just to in its color channel, it just to transfer the RGB image to the CIE lab image, and then goes with k-means clustering to measure the distance to the colors and space to the pixels point to clustering point to measure the distance, and ultimately make a convergence in some set value threshold. then the SLIC superpixel segmentation has been finished. As you can see in the bottom right corner, the third color is the result of the SLC algorithm. And then we do some code segmentation under the constraint of green frequency mapping and green threshold, because we just wanted to select the candidate bubbles in the after SLC algorithms pictures. So we use some technology which is similar as a padding in neural network calculation, and we got the local maximum points. And then if the point is the threshold of the point is larger than the surrounding 8 pixels, it will take as the local maximum green threshold. And then after this stage, we got the results of the fourth color. As you can see, we just we just select some candidate bubbles in a really brilliant result, but there are still some interference, left atrium, contour, and some other noises. Just as I had told before, the shape of bubble is quite unusual, and in very normal thinking, sometimes bubble like we just play a game. The bubble is just like circle or just elliptic one. And then we make some experiments to make some constraint of geometric of circularity, which means to use some geometric constraint to limit the bubble's shape. And then after this stage, we got the fifth color's results is pretty brilliant. It just can very easily. It just can easily to discriminate the fourth color's result, and after this stage, we have saw that the project may has been finished, but in later analysis and the other image, we just can find the algorithm very has adapted to the bottom two rows image. It can very easily to discriminate a candidate bubble or non-bubble, whereas it doesn't have strong robustness to describe some candidate bubbles or some image which was by the motion artifacts or just the noises. So make further studies in space domain. Then we do some radiomics techniques to extract some candidate positives fixtures to in order to discriminate the positive and negative one, and we have just to use open source package Tour Core radiomics to extract almost 660 fixtures, and then we use feature selection methods as lasso to select those features and got certain effective features. Then Combined with the SLC algorithms results and the second stage radiomics results, and we use SVM support vector machine to make a final classification. Finally, we also make experiment with the online radiomics masses. Results show that we have achieved improvement in specificity in AUC. As you can see in the bottom right corner. Then we also make a comparison experiment with the physicians. Although we don't have achieved improvement in diagnosis of patient for over, we have a long distance with the compared to the senior title physician. Our algorithm have achieved some improvement in especially in accuracy and sensitivity in diagnosing the patient for over, which also proved the significance and value of our work. The last one is the discussions of our project. Before finishing the current masses, we have also tried some other deep learning masses, because when I get into this project, at very first stage, I use some sort of deep learning masses to make a direct classification, but results are not brilliant and promising. That is to say, we have tried a lot of deep learning masses, but that masses didn't achieve the baseline level. So we don't use other more deep learning masses in our current master, except the segmentation. When we choose to use the deep learning masses, the very normal one can achieve the baseline level. If we make more complex masses, I think the situation will be more complex. But I just want to make this simple introduction of our previous trial, because we have to do a lot of work in this field. The first one is just very normal CN. We just use the sort feature extraction network, the dense net, to make a direct classification. But the result was not good. I just remember it have achieved about 50% classification rate. The second one, considering that is a video, we have utilized the recurrent neural network to utilize the temporal information to make a final classification. Neither the LSTM and conv-LSTM achieve a good results. And the third one is we add CN and on to make a final classification. The first step is to use CN to make some feature extraction, and then we just got the concrete feature map and send the feature map to the recurrent neural network, but the result was also not promising. So we just give out to use current neural network methods to make a direct classification. And then we change our research direction, because our project, the key point of our project is to detect bubbles and find bubbles to make a final classification. If there are bubbles, we take it as a patient for over. But if there are, we didn't detect any bubbles, or if we are not we are not misdetected bubbles, we take it as normal cases. So we did two work. The first one is just to just detect the left atriums, and then detect the bubbles. We just use a pre-trained faster RCN detect the left atriums with just about with a few labels, just about 300 to 500 label images to detect the left atrium. Result was pretty promising and can just reach about 95% accuracies. Then you can see the middle row in the third column. We can just make a quite good prediction to detect the bubbles, and we also achieve about 0.79 AP for detecting the bubbles. That's the first try in object detection. The second one is from our careful analysis. We found that there are some bubbles will just go through the left atrium to the left ventricle. So we hypothesis whether we can find the bubbles in both the left atrium and left ventricle to make a bubble classification. And that is to say, we just to make a segmentation or detection in the two structures. We just make a bubble detection. Considering spending a lot of time in this project, because I have just spent almost 2 years in this project independently, I don't know whether I can make further improvement in this project. So I stopped this project at this time, and because my previous boss is go to another university, so I have to stop my work. After doing a lot of research in this project, I saw a lot about our current methods limitation. The first one is the data. Compared to other clinical projects or normal CV tasks, I think we have pretty less data, just about 200 data. At the very beginning of this project, our collaboration partner has our collaboration partner has issued has union almost 6 hospitals to collect the data, and we anticipated to collect almost 1,000 cases. But so far we just collected about 500 to 600 data. Unfortunately, most of the data is unvaluable with really bad quality. We have to use only 200 data to make our current work. So I think in the future, if others wanted to do this project, they should consider the large number of data, the high quality data, and even some more heterogeneous data to improve the algorithms robotics. The second one is just a temporal information. From our current methods, I think we don't quite fully use the temporal information. We just use some. We just select the part of the sequences in the complete cardiac cycles. We detect bubble and calculate the candidate bubbles areas radiomics features, and then average radiomics features and make a final classification. I think in the future, we should take more consideration in temporal information, because our data is a video, just like the computer vision's action recognition. There are a lot of information behind the videos. In normal clinical diagnosis, the doctor will always play the video back and forth in order to make a final diagnosis to find the bubbles. So I think more strong algorithms should be considering this field, especially some optical flow or just more accurate frame choice mechanisms in these areas, or even can considering to adopt some very important frames to make frame fusions to compress some very important features to help network to make a final classifications. And the third one is the interference. Noises make great influence on the detection task. I think in the future is more robust and fine neural networks should be designed to this disease environment. I have read a lot of paper in 2D dimensional left ventricle segmentation. They use more robust algorithms to segment the left ventricle to measure the ejection function, and they achieve a pretty good results. But I don't know where their algorithm can adapt to my very complex environment. And the second one is just as what I have said before in the previous talk. 10 years ago, the first one using the engineering methods in Foramen Ovale, they have used some engineering methods to imitate complex environments in the heart. So I think maybe we can make some other experiments to imitate the noise environment to improve our algorithms' robustness and to accurately find the bubbles. And the last one is from other clinical aspects. The expert gives some accomplishment to my current methods and talk about some challenging in this project. And he has suggested us to how about consider other structure, not only focus on the left atrium, because our collaboration partner has told us diagnosing the patient for Ovale is not only just up to finding the bubbles, whether appear or disappear, or appear or not appear in the left atrium, because the bubbles will first will appear in the right atrium and will just go through the Foramen Ovale and then get into the left atrium. So they must pass the Foramen Ovale, and there is a clinical structure called actual spectral, which is a very important anatomic structures. So we should pay more attention from clinical aspects. That is my current work. Thank you for your attention and time. If you have any problem, don't hesitate to email me.